When an osteoporotic spine absorbs a compressive force, the compromised microarchitecture of the bone gives way. The result is an anterior wedge fracture, a structural collapse of the vertebral body itself. These fractures generate an immediate, massive clinical burden. Patients experience severe, incapacitating back pain, and multiple adjacent collapses cause progressive thoracic kyphosis, severely restricting pulmonary function and daily mobility. This T2-weighted magnetic resonance image reveals the internal trauma. The bright white signal indicates acute marrow edema, proof of an active, severe inflammatory response inside the biconcave compression fracture. The standard interventional response to this trauma is percutaneous vertebroplasty. It involves inserting a large caliber needle directly into the fractured bone and injecting polymethyl methacrylate, or PMMA, bone cement. The proposed mechanism of action operates on two physical principles. First, the PMMA hardens into an internal cast, mechanically stabilizing the fragile bone architecture. Second, the polymer synthesis generates high temperatures, theoretically burning away the local nerve endings responsible for the pain. The medical community universally adopted this procedure because it makes perfect intuitive sense. It marries a straightforward mechanical engineering solution to an immediate surgical action. Initial observational data validated the engineering logic. Open-label studies documented that 85 to 100% of patients experienced rapid, profound pain relief almost immediately after the cement cured. To verify these claims, we turn to the 2018 Cochrane Database of Systematic Reviews, the recognized gold standard for rigorous, synthesized medical evidence. When the Cochrane researchers isolated trials that utilized strict, double-blind, sham-controlled methodologies, the data told a different story. The perceived efficacy of the surgery completely flatlined. We are left with a clinical paradox. A mechanically sound, physically permanent injection of bone cement yields the exact same clinical outcome as a simulated fake surgery. Resolving this cognitive dissonance requires dismantling how medical professionals measure the physical success of a procedure versus the psychological impact of the placebo effect. To understand the Cochrane findings, we have to isolate the variable of patient blinding in surgical trial design. Trials that compare vertebroplasty to conservative, usual care are inherently flawed. When a patient knows they are receiving a high-tech surgical intervention, their subjective reporting of pain improves, creating an open-label illusion of clinical superiority. This animated model shows how researchers corrected that flaw. The Cochrane Review identified 5 specific trials, comprising 541 patients, that utilized a strict sham control. The patient experiences an active operating room environment, but receives 0 cement. Surgeons deceived the patient's nervous systems by perfectly mimicking the physical sensation of the surgery. They administered local anesthetic, made an incision, and performed blunt tapping of the vertebral pedicle, deliberately stopping short of penetrating the bone. They even manipulated the sensory environment. Surgeons opened the PMMA monomer in the operating room to ensure the patient smelled the distinct pungent chemical odor of the cement mixing. By perfectly mirroring the sensory experience, researchers isolated the true biomechanical effect of the hardened cement from the powerful psychological impact of medical theater. In clinical research, a statistical difference is irrelevant if a patient cannot feel it.
We measure true efficacy using the minimal clinically important difference, or MCID, the required threshold a treatment must cross to meaningfully improve a patient's life. This chart shows the primary 1-month pain outcomes measured on the visual analog scale. To matter clinically, the procedure must beat the placebo by a minimum threshold of 1.5 points. At 1 month, the placebo group rated their pain at 5.0. The vertebroplasty group rated theirs at 4.4. The absolute pain reduction provided by the cement is exactly 0.6 points. It falls entirely below the required 1.5 MCID threshold. This chart now shows the physical disability metrics, utilizing the 23-point Roland-Morris Disability Questionnaire. On this scale, the MCID requires a 2 to 3-point improvement. The placebo group scored 14.2 against the vertebroplasty group's 12.5. The cement yields a 1.7-point difference, mathematically failing the MCID again. Disease-specific and overall quality of life scores confirm the same reality. Across every primary metric, the intervention fails to cross the threshold of clinical importance. The dramatic pain relief observed by clinicians in open-label settings is mathematically indistinguishable from a highly choreographed surgical placebo. A medical intervention that provides zero unique efficacy must possess an acceptable risk profile of exactly zero. Vertebroplasty fails this rule of asymmetric risk. The primary mechanical danger is cement extravasation. The viscous PMMA can leak outside the target vertebral body while still in its liquid state. If that leakage breaches the spinal canal, it encroaches on highly sensitive neural tissue, resulting in severe cord compression and persistent radiculopathy. The systemic complications are equally dangerous. The literature documents deep bone infections like osteomyelitis, and in severe cases, the cement migrates into venous pathways, causing pulmonary embolisms and respiratory failure. Furthermore, altering the biomechanical stiffness of a single vertebra increases the strain on adjacent segments. The Cochrane data shows no protective advantage over conservative care in preventing new symptomatic fractures in the surrounding spine. The procedure exposes a highly vulnerable osteoporotic demographic to systemic, life-threatening harms in exchange for zero measurable clinical gain. Sensitivity analyses embedded within the Cochrane report establish a definitive pattern. Unblinded trials wildly overestimate treatment benefits. When both the patient and the surgeon know an intervention occurred, performance and detection bias corrupt the data. We attribute natural tissue healing and the placebo response directly to the surgical tool. The data proves that the internal mechanical stabilization provided by a PMMA cast yields zero advantage over a brief period of bed rest and gradual mobilization. Objective, high-grade evidence must always supersede anatomical theory. No matter how physically plausible the mechanical logic appears, the rigorous data invalidates it. The conclusion is absolute. High to moderate quality data strictly does not support the routine use of percutaneous vertebroplasty for acute or subacute osteoporotic fractures. Medical professionals must recalibrate their risk-benefit calculus, abandoning an intervention built on theoretical mechanics rather than proven efficacy. The ethical imperative is clear. Providers must inform their patients that the potential for severe procedural harm vastly outweighs the absence of any distinct measurable benefit.